About coaching surgeons, like athletes, that we use athletes, the coaching the athletes, professional athletes. As such, does the professional surgeons need coaching by the senior surgeons?
Advice.
How you improve this professional surgeons the performances after they train?
First, we need to be confident in our younger colleagues, and we must understand that they also must learn with their mistakes and errors, and but at the same time they must realize that they need to be able to call for help. And one of the things that I was attentive on that, and in these last 7 years, coming back to the number 7, in these last 7 years, I could pay attention to that, and people sometimes are very reluctant calling for help or calling for the seniors. I don't know if they are afraid that we take care of the business and pull them out or something like that, but really it should not happen. But we must be confident on them, and I think they must be confident on us. We have to show them we are not there to put them out or to take the job from their hands, just to take a look and give an opinion, and if necessary, we can go in and help them too, of course. I don't know if I answered to your question.
Yes, sir, you have answered. Do you think that when the surgeons retire, they can call upon to the surgical theaters and look as a spectator of the junior surgeons and advise? Does that work?
Well, it depends a lot from the countries. In Portugal, when you're retired, you are not allowed anymore to go back to the institution, to the hospital. You retired, you are out. You can go there for a coffee, but you can go there for the operating room. But anyway, you have a cell phone, and I have that. I am happy with that, with the guys of my group, because they call me frequently. They once in a while, even if they are in a hurry, and hey, what, saying things, nice things like this. Hey, prof or doctor, your hand and your head and my hands give a great surgeon. So I stay very proud of that. But really, I think it's important to call for help, if not when you are physical present. But today you have cell phones everywhere, and you can show what they are doing and give an opinion.
Thank you, sir. Professor Elmin is there? Professor Elmin?
Yes, I'm here.
Madam, my question is, as a surgeons, we also work as administrators. Sometimes we are mentors, sometimes we are advocates. So how do you advise to keep a balance on while you are performing surgery? How you become an academic surgeon, advocate, administrator, as well as the teacher? Is there a way to keep the balance, or you should more concentrate on one part of your surgical career? How do you advise when maturing from a young surgeon to the a senior surgeon and ultimately master surgeon?
I think you're asking the wrong person. I'm not balanced in any way whatsoever. I have that same situation where there's an incredible load of academics and expectations from the university, management issues, a very, very difficult hospital environment to the operational issues are immense. There's never enough people, there's never enough staff equipment. I think we just get used to having to triage everything, I guess. That's what we do. We triage all the time. I triage emails. I triage, everything that people want from me and want me to do. And it's very hard for me to say no. I think we must learn to say no. I get that advice all the time. Everybody tells me that you must learn to say no. Instinctively, I don't say no because I want to experience everything. I want to do everything. I love doing all the things I do. There's just not enough time in the day. So I'm not going to give you good advice on that. All I can say is sometimes some things have to wait. And if it's waiting from hour to hour or day to day, there are things we have to do right now. And that's usually patients, people, family, a little bit lower, but it comes in. And then there's admin. But some admin becomes very urgent if you don't do it right now. So there's always something urgent in my life, on my schedule, every day, something that I should have done yesterday, but I couldn't because I was operating or I was doing something else. And I think that it's a reality. It can cause a lot of stress. We have to deal with the stress of not being able to do everything as well or as quickly as we want to. But there's some things going to not be done and some things are going to wait, and that we have to make peace with. Alternatively, we need to exclude some parts of our career commitments. And yes, there is decisions to be made. Unfortunately, the hours of the day are just not enough sometimes.
Thank you, madam. Dr. Norman, any questions for the panel?
Yes, I have a question. This is from Dr. Heru Sutanto from Indonesia. She wants to ask Prof. Gastillo, does it mean that the MES score still have to be considered in an acute trauma setting for amputation? Or is there an update in that scoring that will help us decide what's best?
I believe that the MES score has a place for it. As I mentioned before, countries where at times they would come to you late, that sometimes a decision right away, like a below knee amputation, is preferable than trying to save a leg. In our experience, it takes at least 2 years for a type 3B or type 3B3C open fracture to go back to work by saving the leg. So if you can do a below knee amputation, the prosthesis now is very functional and you can go back to work within 6 months. One has to be realistic of what you guys are doing. Other one that I really would ask the panel and everybody that it's essential we advocate certain method of treatment to really have a broad medical record system. Like now, for instance, we have a computerized medical record system. We are paperless, both in the inpatient and the outpatient. We have one person that really calls this patient, what happened to them, so that we know what the outcome is. Many times, we advocate, particularly in the field of trauma, that 3 to 6 months is not enough. You have to find out in 2 years or even in 5 years what the results are. So, and that's the real thing that I would like to emphasize, that a good medical record system in trauma is essential. I found that out when I was viewing thousands of charts in our medical record. Then after that, I computerized our department. Thank you.
Thank you,
Professor
Professor.
Gastillo, have you got any comments about MES score in war trauma, war limb injuries, combat limb injuries?
What do you mean, Miss?
The mangled extremity severity score.
We just make a decision right away when they are up to 7, over 5. We consider seriously really an amputation. There's no question about it.
Thank you, sir. So I have got a question for the panel. that that during the professional development as a surgeon, sometimes after we certain level, that our learning become a standstill, it become flattened, and for that there's a Dr. Anders Ericsson called for deliberate practice, that you have to be more conscious about your practices. My question to panel is any advices, any wise wisdom thoughts about how you migrate from just a professional surgeon to the master surgeon? Dr. Mansoor, sir, are you there? Was Mansoor?
Yeah, he left already.
Okay. Anyone from the panel? How you advise to become a master, just from the migrate from professional surgeon to the master surgeon?
May I?
Yes, sir.
When the guys that are older than you disappear, when they retired, you have no option, you become a master. Well, unless you are a genius like Cristiano Ronaldo, but otherwise you feel that when you understand that the guys that were older than you are not there anymore. Like at home, it's the same as in family.
Any questions, Santos, for the?
I
Yes,
mean,
sir. Professor Ramon.
the concept of professional to a master is wrong. What we have to do is to establish basic principles so that residents and ordinary students can follow it all the time. You know, and teachings that's based on clinical research and follow up and data is there to support the concept. Like when I first started, antibiotics were given for 10 days to 2 weeks. All our studies show that you don't need antibiotics for 10 days to 2 weeks. You know, just as simple as that. And closing the wound, for instance, you cannot put metal in open fracture because it's infected. Well, that concept is wrong because we have shown time and again that you can apply the metal or internal fixation in open fractures, provided there's the right environment and something that you have done. So I question your question of from ordinary to a master. To me, all of us have to be good surgeons following basic principles of treating trauma.
Professor Elmina, another question to you, that when as female surgeons, some female surgeons' attitude for selecting particular subspecialties that's particularly suiting for the female surgeon. What's your idea about that? Sometimes pediatric surgery, breast surgery is their preference. Any comments about it?
Well, I think that is wonderful, that people can find something that they really enjoy, and it also can be molded or organized in a way that it fits with their lifestyle. Surgery is a very strange condition, surgery as a career. People choose surgery not because it's going to make them rich. It's not because it's going to be something that's good for your lifestyle. People choose surgery because they are passionate about it. And sometimes that is wonderful when you have these residents, you can get anything out of them because they're so passionate about getting that operation that they'll work very hard just to get that opportunity. So they're driven by passion, and that's sometimes useful, but it can also make us make stupid decisions, and people find themselves in difficult situations where their families and their other aspects of their lives. So I think it's great to be able to choose a subspecialty that suits you. It's not just women that do that. I object to that thought. It's men do it as well. And the reason for that is we all want to feel in control. So it's it's fantastic to be able to know everything about your field. It is the feeling of control and of being an expert and having the limits of, knowing even the limits of that field. It is very rewarding, and you can be really good. You can do really good work for your patients, and you can be the master surgeon, because now you can know everything there is to know about something small. I think we should all strive to that. And if the world was easy, we could all choose something small in that field that would suit us. Unfortunately, many of us have to fill all the gaps. There's a need for this and there's a need for that, and you end up being a multi-organ surgeon, and you can't let go, because if you let go on that side, there's a need and there's nobody else filling that gap. And that's why we all develop so many different things, but it's not ideal and it's not necessary. So if there's a gap to do a subspecialty and be an expert, I'm all for it, not just for women.
You talk about the shift duties as a trauma surgeon. Will it affect the loss of ownership, both sides, for the patient side as well as the surgeon side? Doing a shift duties as a surgeon, will it cause loss of ownership?
Yes. I think trauma surgery in many countries has become a trauma and critical care. And a lot of people enjoy trauma surgery because it's a critical care side that they really like. The physiology of taking care of blunt trauma patients, and then the anatomy of the penetrating trauma. But, and for me, I like the patient care. So I like that continuity. I want to see the patient when they come in. I want to resuscitate them, want to operate them, and I want to know that in the critical care environment that they're getting the right critical care. But for other people, that's not so important. So some people would enjoy the surgical aspects, and then they'll happily hand over the patient and go home. And that could be a useful way to set up, to structure your system to suit certain people, because there'll always be somebody on call to do the emergency surgery. And that's why acute care surgery fits well in an environment where there's not a lot of trauma, so that trauma and acute care can be joined. And the colorectal surgeons can go home at 5 o'clock, and the acute care surgeon will take care of the diverticular bleed and the perforated ulcer. And there'll always be a shift, and somebody will be there, and they'll go home the next morning, and nobody's been harmed. So it depends on the system. And I think that for me, I'd rather take care of the patient throughout. So I'd rather not go home if my patient is sick. But for other people, they'd rather hand over and go home. So it depends on the individual.
Thank you, Madam. Richard, any question to the panel?
I actually have a question. As a junior consultant just starting out my practice, I'm just thinking, Prof, you're talking about being in control. I'd just like to pick the brains of all these experienced surgeons that we have here today. Have there ever been a time where you felt like you were not in control maybe as a junior surgeon, and what do you do at that point in time?
I think it would be, if you asked honestly all the surgeons to say to you, of course, there was a moment, one moment that I thought maybe I'm not in control. But then, of course, trauma surgery teaches you your brain to say, what are the options? If you're in a single organ surgeon and you're bound by protocols, you don't think in terms of options, you think in terms of protocols. This is what I should do. This is the next step. When you're trained or working in trauma, your brain is, okay, what are my options right now? I can pack and press, I can put a clamp on, I can Pringle, I can aorta, you have a set of options. That's how our brains work. And therefore, if there's a moment where control is lost, one can revert back to several things. So you can revert back to your basics. Where do I start? What's basic here? Get, vascular control, or is it about opening the wound a little bit more, or is it about getting another assistant, or is it about calling, your boss and asking for opinion? or your brain goes into what are my options? And options, I think, is the trauma way, but ultimately it's about staying calm. So even if you're not in control for that moment, it's okay, because you can regain control. And you regain control by breathing deeply and looking at everybody around you and ensuring that they are doing what they should be doing, especially the anesthetist and the assistant. And by doing one step back, there's always a way to have control. You can always press or back or put a balloon in or put a finger on or just hang in there for a moment. And even if it's, sometimes you actually need to see the bleeder in order to get the bleeder. You know, an arterial bleed is visualized, then you know where to put the clamp or the stitch. So there is the moment of loss of control is sometimes built in to what we need to do. The loss of control is what helps you to get control for a moment. But you shouldn't be out of control for more than a moment. But I teach people, have a set of options in your mind so that you can choose. And while you think about your options, blame the anesthetist. That's my plan.
Thank you so much.
Okay.
So one last question to the Professor Gastillo. So what is your opinion, any tips, technical tips about using negative pressure wound therapy with vascular trauma? Extremity vascular trauma, Gastillo 3C, negative pressure wound.
That's one thing you have to be very careful, because usually we don't, because it sucks the, even though you have sutured artery already, it can disengage that by suction. So in general, we try to avoid in type 3C open fractures, the back suction. That's why I'm really looking forward to this bone pit I was talking to you about, because right now it's in the process of being approved both in the States and in Europe. When this comes, it really delivers high concentration of antibiotics, and in 3 weeks it absorbs. You don't have to take them out. And the antibiotics is doxycycline. And why doxycycline? Because doxycycline penetrates bone better than any other antibiotic. So I think that's probably the reason for it. I just wanted to make a comment regarding, in our institution, like the general surgeon is in charge of the emergency room, so that the abdominal injuries, as soon as they have musculoskeletal trauma, we say the orthopedic surgeon is called, and there's always a neurosurgeon also on call for the head injury. So in essence, the neurosurgeon really is in charge primarily of the abdominal and the vascular injuries. Then, but we put together, because we are in charge of bones, and the neurosurgeon is in charge of the head injuries.
Thank you, sir. Dr. Norman, is there any questions from the audience?
Not so much questions, mainly like comments.
Yeah. I think now we have to wrap up our last meeting
segment,
for this series, and we have to call upon for the certificate delivery to